Welcome to The Explainer. Today, we're putting on our detective hats to investigate one of the most common, yet frequently misunderstood diagnoses you'll ever encounter in a hospital: acute kidney injury, or AKI. We're going to treat the kidneys exactly like a crime scene, systematically breaking down the suspects and the evidence to figure out exactly what went wrong. Here is our agenda for today. First, defining the crime scene. Second, prerenal, the flow problem. Third, postrenal, plumbing blockages. Fourth, intrarenal and liquid biopsies. And finally, diagnostic pitfalls. All right, part one, defining the crime scene. What exactly is an AKI? Before we hunt for the culprit, we actually have to prove a crime happened, right? So what triggers our investigation? Usually, it's a creatinine level that bumps up by more than 0.3 from the patient's baseline. But hey, if they have a super low baseline, a jump of over 50% is your true red flag. And though we don't use it quite as often, if their urine output drops below 0.5 cc's per kilo for 6 straight hours, boom, you've got an AKI on your hands. Now, here's where the detective work really starts. We use a strict process of elimination. You never, ever just jump straight to blaming the kidneys. We always check the outside suspects first. Step 1, rule out the pipes leading fluid in, that's prerenal. Step 2, rule out the pipes draining fluid out, postrenal. Only then, at step 3, do we look inside the intrinsic kidney itself. Moving on to section 2, prerenal, the flow problem. Let's interrogate our first suspect. This essentially boils down to a plumbing supply issue. The kidney just isn't getting enough blood flow. But look at this wild contrast. On one hand, you have true hypovolemia. The patient is physically losing fluid, maybe from dehydration, nasty GI losses like vomiting, or an active hemorrhage. They are literally volume down. But on the other hand, decreased effective circulating volume. This is tricky. The patient has plenty of fluid, but the kidney is totally blind to it. Think sepsis, where toxins make capillaries super leaky, so fluid pools everywhere else. Or heart failure, where a weak pump just isn't pushing blood forward. Or cirrhosis, where blood gets trapped in the GI tract. The fluid is there, it's just not circulating effectively. You've also got to look at their meds, because honestly, common drugs cause a lot of totally preventable prerenal injuries. Stuff like NSAIDs, IV contrast, and calcineurin inhibitors, they act like a vice grip, clamping down on the afferent arteriole that feeds blood into the kidney. Overdo the diuretics, and you just get plain old dehydration. Meanwhile, ACE inhibitors and ARBs dilate the exit pipe, the efferent arteriole, causing pressure inside the kidney to totally drop, which tanks your glomerular filtration rate and sends that creatinine through the roof. Quick tip, if you suspect a prerenal issue, scan those lab results for the magic number 20. A bunnet to creatinine ratio greater than 20 is a huge clue. You know what it means? It means the kidney itself is actually completely fine. It just thinks you're dry, so it goes into survival mode, desperately hoarding sodium, urea, and fluid to boost blood volume. That pulls urea right back into the blood, shooting your bun to creatinine ratio past 20. All right, section 3, postrenal, the plumbing blockage. So fluid is making it to the kidney just fine, but is something stopping it from draining out? If a ureter or the bladder gets blocked, all that fluid backs up. It's like a traffic jam. The pressure builds and builds, dilating the ureter and the kidney, a condition we call hydronephrosis. Eventually, the pressure gets so intense, the kidneys literally can't do their filtering job anymore. Your usual suspects, physical roadblocks. Think severe BPH, kidney stones, nasty masses or malignancies, or even a neurogenic bladder that simply refuses to empty. Listen, do not fall into this massive trap. Just because your patient is urinating does not mean they're in the clear for a postrenal AKI. They could easily have a unilateral obstruction, one blocked ureter, while the good side is still putting out urine, but that backed up side is still suffering an acute injury. Always check those post-void residuals. Better yet, grab the point-of-care ultrasound, point the probe marker to their head, and actually look for that hydronephrosis yourself. Which brings us to section 4, intrarenal and liquid biopsies. Okay, we've cleared the pipes leading in and the pipes draining out. Now we break into the vault itself, the intrinsic kidney. When nephrologists look here, they rely on what they call liquid gold or the liquid biopsy. And the best part? You don't even need to cut into the kidney. You just need 10 measly milliliters of urine. Spin that down in a centrifuge for 5 minutes at 5,000 RPM, and you get this tiny pellet. Put that on a slide, and you've got the ultimate magnifying glass to examine your microscopic evidence. This cheat sheet right here, Absolute gold. Spotting these specific casts instantly narrows down our suspects. See clear, glassy, bland hyaline casts? You're almost certainly looking at a prerenal issue. But if that slide is active, lots of dots and muddy brown casts, bam, you've got acute tubular necrosis, or ATN, red-handed. White blood cell casts, that points straight to an inflammatory response, like acute interstitial nephritis. And if you spot dysmorphic red blood cells with those weird little blebs that look like Mickey Mouse ears, that means those cells were violently squeezed through a broken filter. Classic glomerulonephritis. To keep things organized, we divide this intrarenal damage into 4 distinct anatomical zones. It could be vascular, like an infarct or vasculitis. It could be the interstitium, all fired up and inflamed by meds like NSAIDs, PPIs, or sulfa drugs. Glomerular, showing up as nephrotic or nephritic syndromes. Or it could be the tubules. And honestly, the tubule is where you really want to focus, because ATN is the culprit a whopping 90% of the time when you're looking at intrinsic causes. Now, keep in mind there are 2 completely different ways to kill off those tubules. First up, ischemic ATN. This happens when severe hypotension, often from sepsis, tanks the blood pressure so hard that the tubules literally starve of oxygen and die. Then you have inflammatory ATN. Even if the blood pressure is totally fine, the tubules can be absolutely wrecked by the systemic inflammation of sepsis, toxic drug combos like vancomycin, or crystal urea precipitating right in the kidneys. Finally, Section 5, Diagnostic Pitfalls to Avoid. All right, time for some serious myth-busting. Even veteran detectives get thrown off by bad evidence, and some classic tests can lead you completely astray. Let's start with a big one, the fractional excretion of sodium, or FENA test. We're all taught that if FENA is greater than 2%, the kidney is dumping sodium, meaning you've got intrarenal damage. But we really have to ask, is this test actually helping our management today? Well, usually, no. Get this, the original trial that made the FENA test so famous only looked at 17 oliguric patients. Just 17. In the real world, a lot of nephrologists will tell you it rarely changes what they actually do. If the patient has a classic prerenal story, you give them fluids and see if they get better. If you suspect an intrarenal cause, you get the liquid biopsy and spin the urine. FENA often adds 0 value and is literally part of the Choosing Wisely campaign because it's a test we constantly order for no good reason. Here's another massive trap to avoid. You absolutely cannot trust computer-calculated GFR during an active, rapidly changing AKI. Think about it. If your patient's creatinine jumps from 1 to 2 overnight, the electronic medical record might happily spit out an estimated GFR of 45. But what's the reality? To double your creatinine in just 24 hours, your real GFR for that day was essentially 0. If you're out here dosing dangerous medications based on a totally fake, reassuring GFR of 45, you could do some serious harm. Same goes for the urine protein to creatinine ratio. Never, ever trust it during an active AKI. It's almost guaranteed to be totally inaccurate and falsely elevated. You might run it and see what looks like massive, scary, nephrotic mange proteinuria. And the real danger isn't even in that moment. It's that this bogus data gets permanently logged in their chart. Fast forward 10 months, another doctor reviews the file, sees that fake reading, and they completely mismanage the patient's care based on a ghost. Which brings us to our final thought. The next time you look at a chart and see long-standing nephrotic syndrome scribbled in the history, you really have to ask yourself, is that real? Or did a past detective get totally fooled by a false protein ratio from an old AKI? You've always got to question historical data. Trust your systematic process of elimination, spin the urine for that liquid gold, and apply this exact schema. That's how you become the ultimate medical detective for your patients. Thanks for joining me on this explainer.